Now let's look at the midface and the targets that we want to treat with filler. So first of all, let's just remind ourselves about this important division between the lateral and the medial midface. So this, connecting these three dots, is what's going to be dividing our medial and lateral midface. And as a reminder, the lateral midface is passive, and with aging, the tissues can move inferiorly to create laxity along the jawline. Whereas medially, because of the structures that pass through from bone all the way through to skin, for example, the zygomaticus major or the LAO muscle, we have lots of structures transecting the layers. And so instead of sagginess, what we see in the medial cheek is more like volume loss. So that's how we get a difference in aging between these two, either side of this line. The second thing is that we know that if we add volume laterally first, we need less volume medially second. And that's why it's a mistake to start to add volume here first before we've adequately volumized the lateral structures. It's been described that this part of the face is organized like layers of an onion, concentric layers where we can reposition tissues, whereas the medial cheek is more like roof tiles where the tissues are in a and they're not in a concentric layer, but on top of each other with tissues, with structures transecting the layers. And so we have a lot more stability in the medial midface. So my treatment plan today is going to start with the lateral midface. And first of all, I'm always going to want to identify the boundaries of the zygomatic arch. And we can follow the cheekbone like this. Kind of goes like this. Once I'm happy I've found the zygomatic arch, I know the natural direction the cheekbone is going, and so I have the angle of my cheekbone. So that's really important. The second thing we need to do is understand where the apex of the cheek is, the most projected part, which is not an anatomical structure, it's more of an aesthetic structure. And a good way to identify that is to find this midpoint between the zygomatic bone, the midpoint between the orbital bone laterally and this vertical line downwards, that we've already got this. We'll find a nice prominent aspect that we want to create some projection at. So this was where I would say the cheek apex is. And what we can already see is because we've got actually very beautiful natural cheekbones and we've got some volume loss medial to this, this is already well projected. That doesn't mean to say that we shouldn't add a bit more structure, and we're doing that deliberately in order to actually follow our treatment plan principles and make sure that we're not overfilling medially. So I do think we need to add some volume to the apex of the cheek, and then we're going to use a cannula to taper off the zygomatic bone laterally. All of that isn't to try and create lots of projection laterally, because she does have very good, beautiful, defined cheekbones, but it's to start to add this structure, which is going to be important if we're going to try and get the best results in the medial cheek. So this target here is actually our suborbicularis oculi fat, and this target laterally is going deep into our pre-periosteal fat along the zygomatic bone. So this is number one, the apex of the cheek, and number two is the lateral zygomatic arch. Treatment number three is going to be the area behind the line of ligaments underneath the zygomatic bone. This is our preauricular area. We have kind of preauricular, subzygomatic, submalar, if you divided this area into three sections. And all of this can be volumized with hyaluronic acid in layer 2. This is what's going to give a lot of this lovely definition and also tension laterally to the line of ligaments that's going to improve the jawline and the midface. So the treatment sequence number one is going to be the lateral midface, which is going to be the apex of the cheek, the lateral zygoma, and what we would call collectively in this area as the preauricular and subzygomatic and submalar region. So let's do that treatment first. I'm going to just talk about the technique first. So this one will respond very well to a cannula treatment. And I'm going to show you how we use a cannula to treat the apex and the lateral zygoma from a singular entry point, which will be from around here. Remembering that in this part of the face, we can treat in the souff or we can treat in the pre-periosteal fat. In this case, I'm actually interested in as much structure as possible. So I'm going to be treating in the deepest plane, which is the pre-periosteal fat, which is actually a structure that lives even deeper than the souff.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
Okay, so let's make our entry point for the lateral zygoma first. Little scratch. So I'm using a 22 gauge cannula, and I'm just going through the dermis with the needle. And then let's talk about the layers that we need to move through. So if we go into the subcutaneous plane, we need to move underneath the orbicularis oculi muscle. So this is that tethering and dimpling there. So there's a little pop. There. So now I'm in the souff. This is the suborbicularis oculi fat. The thing I want injectors to appreciate is that we can also go a layer deeper than this. There is another fascial plane, and then there is a fat pad called the pre-periosteal fat. And that is actually what I'm going to add volume in today, because I'm trying to create as much deep structure as possible. So if I go even deeper, there's a second pop. And that is now me gliding truly down onto bone. This is where I'm going to add some projection at the apex of the cheek, where I want the maximal light reflex. Once I've done this, that's about 0.3 mils of Revenus contour. I'm now going to move back into my subcutaneous plane like this, and then move along the zygomatic arch itself. I don't need to be deep yet. I don't need to start treating the deep plane until I get to this point, where I'm going to again perforate through the orbicularis oculi muscle, and now I'm moving in the deep plane along the lateral zygoma, the zygomatic arch. The reason I'm choosing this deeper depth is because, again, this is about deep volumizing, and I want to create as much structure as possible so that it enhances my medial midface treatment. Just trying to create as much of a smooth transition here from the lateral zygomatic arch through to this apex that I've created at the cheek. And that's half of the syringe of filler used for that treatment. So we can just take a look now. Really important that we don't flatten this gel. So we've created a really nice deliberate shape now, and if I use my thumb to press, then I'm going to spoil that. So I can use my finger to roll like this, and that's going to be a nice way to create some definition. But otherwise, we have a nicely defined apex of the cheek and some lateral projection. Let's have a look if you sit forwards. So we can start to see some very nice shape on that cheekbone compared to the shape of this one. We're a little bit more angulated, a little bit more projected and defined. Okay, so now we're going to work on that. But the next thing we're going to do, come back, is treat this lateral midface in the subcutaneous fat. Again, using a 22 gauge cannula. And for this one, I'm going to do an entire syringe of filler to replace lost volume in the subcutaneous depth. So this entry point is now facing horizontally, and again, just into layer 2. Okay. Thanks, Max. So we've got some cannula tricks and tips. Do you want to talk us through some of these, Max, in this part of the face?
So in this part of the face, staying superficial is key. One of the easiest things to do is to not be able to see and feel your cannula and dip down. And what's beneath this layer is our parotid gland. And ideally, we don't want to be adding filler into that. So if you can't clearly see the outline of your cannula, coming back towards your entry point, you don't have to come all the way out, finding your plane again, and then staying nice and superficial. Whenever you're in that subcutaneous layer as well, you will often feel some resistance, and it's very difficult to reposition your cannula without coming back towards your entry point. So if you're all the way in and you want to angle down 10, 15 degrees, that'll be very challenging. So as Tristan's doing, coming all the way back, changing your direction, and then advancing again. What's tempting to do whilst you're doing that is to keep injecting filler as you come all the way back to your entry point, but then you'll end up with a concentrated area right by your entry point where you've deposited lots of filler. So have a point where you're going to stop injecting filler, which for Tristan is about there actually. Stop injecting, come back, reposition.
Yeah, so about here, I wouldn't be injecting this little part of the track every single time because, as Max said, it can create a nodule of filler, which we don't want. Okay. Great. So this one, it's okay to massage. Okay, we're going to create these little linear tracks under the skin, and we just want to try and flatten those, help the product spread evenly under the skin. When we're using a low viscosity and highly cohesive gel, that's very straightforward. Okay, now I'm going to take off some of the markings on this side, and it would be great to compare one side to the other. So we haven't treated the medial midface yet, we've just treated the lateral midface, creating some definition at the apex and also the preauricular. So let's take a look, sit forwards. Great.
Very nice.
So we're starting to get this lift along the jawline in particular. This is significantly lower than the height of this over here. So we start to see this lifting effect. Head back. So now we're going to focus on the medial midface, and I'm going to do the drawings on this side to illustrate the anatomy that's relevant for that treatment. When we treat the medial midface, the first thing I always do is I just find the inferior bony margin, and that becomes the highest point of any treatment that we would do in the midface. This is the origin of our orbicularis retaining ligaments, and we can't, and we certainly shouldn't go above that margin. So anything above there is the eye, okay? We then look, with the patient looking straight ahead, we find this medial limbus of the iris. That gives us where the zygomatic cutaneous ligament will come off and insert into the prominence of the zygoma. And so this is a characteristic shape that you'll see when we're looking at the two major ligaments of the midface, which have structural importance. I've already treated the suborbicularis oculi fat, which is the area living between these two ligaments, and you'll notice that this is where the apex of the cheek treatment was. Okay, so what does that leave us with? Well, what happens with aging is that the fat pads that live in the subcutaneous plane start to move downwards with gravity, and also with the laxity, the elastosis of the skin. And so that starts to reveal something in this area, which is that we have a little bony ledge here. This ledge here is called the palpebromalar groove. And so even though we have restored volume in the apex of the cheek at the souph, we start to see this characteristic bony ledge over the lateral aspect of the under eye. This is not the tear trough, this is a specific groove that's revealed as the tissues move downwards. And we can treat this because it's something that requires additional volume. But the fat pad target here is something called the interlaminar fat, which is the fat that lives between little bands of the orbicularis retaining ligaments. And so this is an important target as an extension of a tear trough treatment to improve the under eye area. The tear trough itself in this case is the gap between this medial aspect of the orbicularis retaining ligament and this groove here, which is called the nasojugal groove. The nasojugal groove is the superior pole of this nasolabial fat pad. And so we've got a very narrow little target here, which is the tear trough, which can then extend to become this palpebromalar groove treatment. That's how I would treat the tear trough. But remember that we generally want to be working from deep to superficial. And so there are deeper targets in the midface that I want to treat before the tear trough. And the first target is going to be the deep medial cheek fat. This is what I suspect was the intended target for the original filler treatment, because we're trying to restore some of this deep volume in the midface. The thing to just be mindful of is if you give us a really big smile, there isn't actually a lot of scope to create too much volume here, especially if that filler moves into the wrong zone. It will move on animation. So if I'm going to add volume here, it has to be deep to the muscles so that we don't have that movement on animation. What we have in the medial cheek, just like we have above the eye, we have the supraorbital and we have the infraorbital foramen. And the infraorbital foramen is obviously deep, emerging from the maxilla. The vessels from the infraorbital foramen move medially like this. And that is an important separator for two compartments down onto bone. So medial to the vessels, we have the deep piriform space. And this is a target that we can inject down onto bone. If I palpate here, I don't actually notice there's a significant degree of recession of the maxilla. So normally this would be a very good target in a deep midface sequence. In this case, I'm not convinced it will add too much value. And so I'm actually not going to treat the deep piriform space. But what I do notice is that we have this volume depletion in the deep medial cheek fat. Okay? So how do we find the deep medial cheek fat? Well, we know it's this entire area beneath the zygomatic cutaneous ligament and down on bone, just lateral to the infraorbital vessel. But this deep medial cheek fat is actually sitting beneath a muscle called the levator labii superioris, which is the roof of this fat pad. And so the best way to get into this deep fat pad compartment is to try and find a way to either get your cannula into the deepest possible plane underneath both the SMAS, layer 3, and underneath the levator labii superioris. Alternatively, we can use a needle and treat it down onto bone. In this case, I'm actually going to use a needle. And the way in which we're comfortable using a needle is because we understand the risk in this area. The major risks in the midface when it comes to the vessels are going to be the facial artery becoming the angular artery, which usually is ascending the nasolabial fold in the subcutaneous plane, and of course this deep infraorbital vessel that we mentioned previously. So considering those, if we take an injection point in line with the mid-pupillary line or even the lateral limbus of the iris down onto bone and inject slowly with a high G' product, that's how I'm going to maximize the chance of the gel sitting in this deep cheek compartment. That's ideally going to find its position beneath the lip elevator muscles and then avoid those problems of movement on facial expression. So let's clean some of this off, and then let's take a look at the injection technique.
What we learnt in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
Okay, so I found my target, which is just sort of in line with the lateral limbus of the iris and slightly closer to the mid-pupillary line, certainly a safe distance away from the infraorbital foramen. And this is an entry point, an injection point which is inferior to the zygomatic cutaneous ligaments, and therefore I'm confident this would be volumizing the deep medial cheek fat. I've got my 27 gauge needle and I'm using Reveness shape. Little injection now down onto bone, nice and still for me. Perfect. And we go deep. We touch down onto the maxilla. And this is where aspiration is going to be really important. Okay, so I'm happy that I'm not really tethering down any of the tissues. And I'm going to do a good 10 seconds aspiration. Okay. Happy there's no blood in the hub of the needle. And really important here that we have slow injection pressure. If we're using a high G' product, slow injection pressure, we're minimizing the risk of filler moving along the needle track into the subcutaneous depths. I'm looking to inject 0.3 mils here.
The great thing about shape is that it's so cohesive as well, so that it will stay in that deeper plane.
Good. Thanks, Max. After injection, we can just gently mold that. But for me now, this has really improved that hollowing in the medial cheek. So let's have a look. Do it forwards. Forwards. So I hope you can appreciate here an improvement. What I noticed though is that there is another area, what we would call the deep lateral cheek fat, which I think we also need to treat.
Yeah.
Okay.
Yeah.
I think both of those deep compartments require volume to create the best aesthetic outcome. So let's do another injection, head back. We'll go for 0.2 mils in the deep lateral cheek fat as well. Head this way. What divides the deep medial and the deep lateral is the levator anguli oris muscle. There. So down onto bone. We aspirate again. Perfect. Sit forwards for us. Okay.
Oh, better.
And really big smile, please. You see we haven't overfilled that aspect of the cheek. Relax. Good.